And thank you for inviting me back to this group. I find it very stimulating to be here. It's, I guess, such an interdisciplinary approach is very valuable. I think that I won't sort of reduce the tension, but I will speak of my day as a clinician, or some perspective from clinical old age psychiatry. And the topic for this lesson, sadness, depression and suicide in old age, is, as one of my acquaintances here told me in a break, it's sort of the bad days as in old age. But I'll come back to what makes it good and what makes it bad in old age. I know no better way to start than to show this picture by Van Gogh, made in 1890. And what we see here is an old man in despair, in frustration and in agony, perhaps also tormented by guilt and by self-reproach. Yet, despite this apparent hopelessness, the title, at least to us, gives a sort of hope for some consolation, perhaps a better sort of outcome that the picture would itself indicate. It can, by the way, also be mentioned that Van Gogh at the time had a deteriorating health, the precise nature of which is unknown, uncertain. He may have had a seizure disorder about a bipolar disorder, or suffering from too much intake of alcohol, absinthe. But his death, about 2 months after the making of the painting, is believed to be a suicide. Thus both the painting and the painter is a fitting introduction to this talk. What I will try to do in this talk is to present some viewpoints from a clinician, to present some of our difficulties and dilemmas in everyday clinical work. Hopefully some of this will be of interest, perhaps even be useful information for your research. Sometimes, and in my experience from the natural sciences, new background or lateral information can provide just the necessary impetus for new results. Perhaps this can also be the case for us now today in this interdisciplinary approach to age and aging. Both in the classic and more modern literature is, in fact, a fact which I'm sure you are well aware, filled with characters showing signs of clinical depression. Amongst them are characters in the novels by Salinger, Fitzgerald, Plath, and Woolf. Now, with regard to medicine and literature and arts in general, or rather with regard to doctors and arts, there are two different schools or viewpoints. One will state firmly that medicine and arts, never the twain shall meet, using knowledge and medical reasoning on characters in the literature or in paintings will be to remove some of the artistic values from these works. A different school, of which I happen to be an associated member, claims that as being doctors, medicine takes up a significant portion of our lives, and we cannot simply stop using that knowledge when enjoying a book, a painting, or a poem. Contemplating on medical diagnosis, questions and their consequences for the characters doesn't subtract anything from the artistic value. It adds significantly to our understanding and associations of these works, whether it is to use our clinical reasoning to investigate the suicide in Ibsen's plays, the neurological signs and symptoms in Shakespeare's plays, or an old man's suffering and death in The Death of Ivan Ilyich by Tolstoy. Some may then describe us as dilettantes, but I do not mind that. Being a dilettante is also to be someone who enjoys science and arts. Indeed, with regard to literature and medicine, some scholars even claim that such studies actually may give information of scientific value to medicine. Did schizophrenic symptoms really exist long before the studies done and descriptions made by Kraepelin and Bleuler, two of the pioneers of psychopathology, or are schizophrenic symptoms a result of the modern industrial society with its new social constructions and new challenges to man? Well, why not take a look in the works of Shakespeare? Surely his precise observations and descriptions from nearly all types of human activity and human endeavors must be equally precise when he's describing mental aberrations. And indeed, we find a number of characters that seem to show the bard's diligent observations and character that by some, it is not undisputable, seem to show signs of schizophrenic symptoms. For example, poor Tom in King Lear. And although poor Tom is Edgar in disguise, pretending to be mad, that only strengthens the argument. One pretending to be mad, that is well known from forensic psychiatry, does indeed try to present classical symptoms of the disease. Another interesting example from the interaction between arts and the medical diagnosis can be taken from the well-known diagnosis of PTSD, post-traumatic stress disorder, an integral part of which are the flashbacks. Flashbacks are the vivid visual reenactments of the traumatic circumstances causing the later problems. The diagnosis PTSD is fairly modern. Earlier terms used were shell shock or combat neurosis. But surely, such typical symptoms as flashbacks after a traumatic experience must have occurred at all times. Actually, that is not the case. Flashbacks were not known or described before they were introduced and used by Hollywood and the movie industry. This is another example on how literature and art can give interesting information regarding the validity of psychiatric diagnosis, important for the psychiatric nosology. Well, now back to old age psychiatry. And as an old age psychiatrist for many years, the situation Van Gogh in his painting depicts is well known. Indeed, depression is one of the famous 3 Ds in old age psychiatry. They are depression, dementia, and delirium. These conditions, depression in particular, covers much suffering and misery. Yet we must remember that most senior citizens for the most part enjoy their long life. Among other things, they meet friends, travel, continue to play bridge, go to the theater, watch movies. And I come to think of my neighbors, 97 and 95 years old. He is a retired judge, an acute observer of law and politics, as acute as ever. And she, well, I guess she is as acute an observer of what is going on in the neighborhood as ever. So how do they make it? I remember the old poet, whom I'm sure you know well, Anacreon. From him we have the following poem. Oft I am by the women told, poor Anacreon, thou growest old. Look how thy hairs are falling all, poor Anacreon, how they fall. Whether I grow old or no, by the effects I do not know, but this I know without being told, it is time to live if I grow old. 'Tis time short pleasures now to take, of little life the best to make, and manage wisely the last stake. Surely there are lessons to be drawn from the old Greeks. Let us see. What are the challenges that many of us meet and will meet in old age? Old age is a period of losses. Retirement means, for instance, we lose our job. Not at all a blessing for everybody. One thereby loses the informal human contact with colleagues, fellow commuters, customers. One loses an activity that regulates daily and weekly rhythms, difference between weekdays and weekends, and so on. And many lose the authority and social standing that comes with a respectable position in the working force. Some enjoy in old age new roles and challenges, for instance the role of being a grandparent, but this cannot in general compensate for the losses we also must endure. In old age we lose friends to sickness and death, often paving the way to loneliness and isolation. We lose mobility. Through deteriorating health we may be prohibited from driving. Often one loses financial freedom. The ordinary income is replaced by a more meager pension. So, what is it in this jungle of psychological dangers that still keep many elderly people sane and still able to enjoy life? Maybe that is the important question to answer, and if answered, giving results that actually may be of importance to the prevention and treatment of depression in all ages. But first I would like to try to explain now depression from a clinician's point of view, distinguish it from sadness and look a little bit on its epidemiology, that is, its frequency in the population over the lifespan. So this is the definition of a depressive episode from ICD-10, International Classification of Diseases, version 10. And what we see here is a rather technical slide, but it's taken from the manual. And as you can see, we have first 3 main criteria, of which at least 2 of them must be fulfilled. Depressed mode, an unusual loss of interest or pleasure, or decreased energy. And then we must have some additional symptoms, so that we have at least 4 in total: loss of confidence or self-esteem, unreasonable self-reproach or inappropriate guilt, recurrent thoughts of suicide, indecisiveness, agitation or retardation, sleep disturbances, or loss of appetite. So this is an example of modern criteria-based psychiatric diagnosis, made in an attempt to make psychiatric diagnosis more reliable and objective. This list obviously seems to also to describe many aspects of the depressive state. But as you may see, it also shows that evaluation of a minor point may tip the balance either way into having a depressive episode or not. That's the weakness of this kind of psychiatric diagnosis. It's sort of categorical and not dimensional. So what then are the main differences between sadness and grief and depression? How to distinguish between them? It may be difficult. The symptoms may be similar and the conditions have much in common. But the depression is generally persistent, while grief subsides. One may be temporarily relieved and distracted from grief, while a depression is pervasive. A component of depression is often a feeling of worthlessness, not usually seen in grief. Suicidal ideation and thoughts, even plans, are common in depression, but not in grief. And why is it important to distinguish between grief and depression? Well, grief is natural. Grief doesn't need the attention of healthcare professionals. A normal grief reaction is not dangerous. We are, in general, made to be able to cope with grief. Depression, on the other hand, is a potentially dangerous situation. It may cause long-time suffering. It may cause somatic disorders through inactivity and diminished food intake. And it may substantially increase suicide risk. And, especially important for the elderly, it may worsen or aggravate a cognitive weakness, ultimately leading to a dementia. It should be added that an abnormal or prolonged grief can be part of a depression and should merit evaluation and possible treatment. So, when depression is suspected, the patient ought to have a proper diagnostic evaluation. And again, normal grief doesn't need anything but comfort, company, and understanding, whereas depression may need and benefit from specific therapy. So, this is, you recognize the picture from Bernd Engelsen's slide. This is Melancholia by Edvard Munch. And what a psychiatrist or a clinical psychologist would do would be to, in a depressive condition, classify the depression as being a single episode, a recurrent depression, or a part of the bipolar disorder. We would classify the current episode as being mild, moderate, or major, whether it has melancholic features or has psychotic feature, that is, you lose contact with reality. And the treatment can be just counseling or support, it can be specific psychotherapy, it can be antidepressive medications, and it can be electroconvulsive therapy, previously and incorrectly called electroshock. So, what can we say about depression in the elderly? Well, there is an increasing prevalence with increasing age. It may be difficult to recognize. Symptoms can be more vague in the older group and may masquerade as cognitive decline or worsening of somatic disorders. So the diagnostic efforts should be broader and more thorough for an elderly person suspected for depression. And it is even more important to diagnose and treat quickly because of the risk for complications. So, a couple of words about suicide. Suicide is one of the leading causes of death. Among certain age groups, the leading cause of death, representing enormous tragedies and causing much suffering to the next of kin. Especially among adolescents and young adults, suicide together with accidents dominate the statistics. But this is because the deaths from somatic diseases are relatively rarer in these groups. Despite the magnitude of the problem of suicide, so much is unknown about the suicidal process in an individual itself, and thus how to reduce the number of suicides. It is well known that depression is a substantial risk factor for suicide. As you also may know, the period where a person is actually recovering from a major depressive episode is a period of high risk. In such periods, the patient may have regained their initiative and vigor, while improvement of the mood sometimes lags behind. This hapless combination is paving the way for suicidal thoughts and attempts. Suicide, however, is also related to other psychiatric conditions such as schizophrenia and drug-alcohol addiction. A number of other risk factors are known. Amongst those are life crises such as divorce, financial loss, public humiliation, serious illness such as cancer, to name just a few. These, however, are useless as predictors. Suicides remain unpredictable in individual cases. I might add that losing a patient to suicide represents a serious crisis for all psychotherapists, for which many will need counseling and support from their peers. The stress for healthcare provider is often accentuated by a subsequent investigation, which somehow carries with it the subtle implication that the therapist should have been able to foresee and to prevent the tragic event. So the main strategy for a healthcare professional must be to identify the suicide risk and the risk factors, to treat a possible depression, or to facilitate, help, give support, install hope in the individual. We see some of the suicide rates here. This is data from the United States, from the Center for Disease Control in 2010. And we see a number of things. See, the blue is the white male. They use the term white and black, so I don't dare to go into that. But the blue and lily is male, while the orange and yellow is female. So we see a couple of facts that males have a higher suicide rate than females, and especially for older males, the risk increases substantially towards the later part of the lifespan. So, with regard to suicide in the elderly, yes, as I said, we see higher suicide rates, especially for males, and there are also possibly more unrecorded cases because they are sort of camouflaged into possible somatic disorders, not taken to be a suicide. They have relatively fewer suicide attempts. Perhaps it turns out that when they have decided upon a suicide, they go through it, and they have fewer attempts than younger age groups. So, some predictors for a good long life. The list is obviously not exhaustive and it's neither ranked, but having good physical health is important. To be in a stable social relationship is important. Moderate to low use of alcohol. And it seems that the time to recover between losses is important. If there are too many losses in a short time frame, it may lead to depression. But when there is time to recover, we may cope with it more easily. And many may benefit from retirement planning for the new life without the structure that a daily work will give. So I guess it all boils down to manage wisely the last steak. And now, returning to my old neighbors, they called us from time to time, preferably to talk to my wife. For some reason, they prefer a specialist in internal medicine to a psychiatrist any time. But sometimes they talk to me when they need a handyman, when there is trouble with the central heating system, or flooding in the basement. The last time they called for me was on New Year's Eve, or rather 10 minutes past midnight, 10 minutes into the new year. Surely that would have to be something very grave and important matter. And indeed it was. They needed help to open their bottle of champagne. So I guess that is a perfect example of little time, the best to make, and manage wisely the last steak. So it's never too late to start enjoying a bottle of champagne. So thank you.